Hi, this is Brian Kim. I'm going to share with you this patient who had a Restor 3.0 and had an exchange for a Panoptix Toric Trifocal IOL. This is his second eye. This is a computer programmer who complained of monocular diplopia in each of his eyes. He also complained of fluctuating blurry vision. And so he was quite happy with his first eye, and so this is his second eye. So the surgery was done quite a while ago, and as a result, I'm making fresh new incisions. You can see I'm making a paracentesis superiorly and inferiorly. I'm injecting some intracameral lidocaine. I'm using a 25 gauge hypodermic needle going underneath the anterior capsulorhexis edge, and I'm using some dispersive viscoelastic. You can see I picked the one area that had quite a bit of overlap of the capsule over the lens. Here I'm going bevel up, but I think bevel down is also quite effective. Now I'm using the cannula, the viscoelastic cannula, again with a dispersive viscoelastic, trying to get underneath the anterior capsulorhexis edge. And so I'm pushing some of that dispersive viscoelastic, finally getting underneath the anterior capsulorhexis edge. You can see I'm sweeping side to side. I'm trying to free up and liberate the anterior capsulorhexis edge. And as I do that, I'm going further and further, deeper and deeper into the capsular fornix, more and more peripheral. And again, you want to be very ginger. You want to push the viscoelastic very gingerly. This is a visco dissection. You want to make sure that the dissection between the anterior and posterior capsule, peripheral to where the optic is, a very slow, methodical process, and that you do want to get a thorough separation of the anterior and posterior capsules. As you push that viscoelastic, you want to be very ginger because the viscoelastic will fill the capsular fornix and then wrap around and go underneath the lens toward the posterior capsule. And if you look real closely, you can see those marks right there. On the left side is the viscoelastic wave from the left side around, and the right side is actually the right side wave that came around. You can see that both sides of the viscoelastic that are underneath the lens optic have not come together quite yet. And so that's good because you don't have a complete overfill of the bag, which can be risky. Once you do that, I'm injecting some viscoelastic in the anterior chamber, and I'm going back and making sure I'm getting now in the area of the haptics, trying to push that viscoelastic, trying to get some separation to separate the anterior and posterior capsules. You can't really rush this process. You want to make sure that the entire capsular bag, 360 degrees, is free of the lens. So I put a Sinski into the paracentesis, and then I'm doing my triplanar corneal incision and make a vertical groove, and then tunnel, and then go in. Because I am intersecting to some degree the original incision bit, I wanted to make sure that I got a really nice incision. So you can see I'm using the Sinski hook getting around the haptic, and I'm teasing it to make sure very gently that the haptic is still not incarcerated within the capsular fornix. You can see that as I'm pulling it, I don't see the capsular bag having any stria or traction, and so I feel pretty good that the haptic is going to be freed. And so you can see it pops up quite nicely with a little bit of effort. And as you're pulling it, you want to make sure again that as you're pulling the haptic, you're not pulling the capsular bag or the zonules. I'm working on the other side, and this one comes out a little bit easier. And because I had quite a bit of dispersive viscoelastic that wrapped around and went underneath the IOL, I didn't really go in and push any more viscoelastic into the bag in this case. I'm using the closed teeth of the scissors to lift the optic so that it can get to my forceps. Again, these are toothed forceps with MST. And as I'm cutting it, I like to turn the teeth sideways a little bit so I can have a more horizontal configuration to the scissors and not more vertical, because if it's more vertical, it's going to be pointed towards the posterior capsule. So I cut all the way across. I'm still holding with the left hand forceps, grab it with the right hand forceps, and I'm grabbing again with the left hand and then grabbing with the right hand. So I did kind of a maneuver with back and forth using both hands so that I could deliver that first haptic, pull it out, and then I'm grabbing the optic edge adjacent to the haptic, and then I'm able to deliver that half of the lens. So using a bimanual technique, I'm using two hands to kind of inch towards the area of the lens I wanted to explant. By doing it this way, you have much more control. And then the second half, it just grabbed it at the apex of where the cut edge was. And since the haptic is on the other side, it was able to come out quite easily. Now I'm injecting some cohesive viscoelastic to inflate the bag. I'm going around circumferentially, just making sure that there's no adhesions between the anterior and posterior capsules here. Now I'm injecting the single piece Panoptix Trifocal lens. As per my typical technique, I have a cannula holding the incision through the paracentesis. The leading haptic is delivered in the bag. I'm using a cannula to very gently deliver the trailing haptic. Really, the capsular bag is not like a virgin cataract eye, and so you want to be quite ginger, make sure both haptics are delivered quite nicely. And this is actually a Panoptix Toric lens, and so I have to make sure I align this lens exactly where it needs to be. I go underneath the edge of the optic, tilt it upward, removing the dispersive viscoelastic from within the capsular bag and between the posterior capsule and the lens optic. You see there was a little bit of cortical material or something that was on the left side, and I was teasing it, but as I did that, I think that that was actually the posterior capsule, or at least the peripheral capsule. And so I stopped aspirating that area. I'm just going around underneath the anterior capsular rhexis edge and just polishing a little bit. And I'm manipulating the lens to make sure it's going to be on axis. That was actually a small fragment of the lens that I explanted. So I must have gotten a little small piece as I was cutting it. Once the viscoelastic is removed from the capsular bag using the Cortex mode, I switch to the viscoelastic mode and removing the viscoelastic in the anterior chamber. I'm pushing BSS with the cannula into the angle to make sure there's no viscoelastic in the angle. But you can see there's still some viscoelastic there. I go back with the INA. Use a lot of dispersive viscoelastic with this technique. When you're doing an IOL exchange or explantation, you need to really use a lot of dispersive. Dispersives, in particular the viscoat, is really good at a mass effect of pushing tissues apart. So viscodissection is really, in my experience, viscoat is really the best viscoelastic for viscodissection of tissue. So now I'm hydrating my incisions. Since this is not a virgin incision and I have a little bit of overlap with the original incision, it's very, very important to make sure you have good closure of that main incision. And if you don't feel confident that there's good closure, you have to put a suture in my experience and recommendation. Whenever you do an IOL exchange and you have interfering incisions from the original surgery, you just don't want to take a chance. And if there's a potential leak, just close it with a suture. So I'm hydrating my incisions. You could see that in this case, I'm fortunate that the wounds closed up quite nicely. And the rest of the time here now, I'm going to make sure that the alignment of the lens is correct and to make sure that the central optic is centered over the macula. So I'm having the patient look straight at the light, and you have a perfect centration of the lens. Thankfully, this patient was ecstatic. He was very particular with his vision, had a lot of unusual complaints, monocular diplopia out of each eye, waxing and waning of his vision. And so we took a chance. Originally, to be conservative, the discussion was for him to get a monofocal lens. However, he was adamant after clear recommendations of informed consent and the potential for having the same problem with the Panoptix. He was able to go forward with it confidently, and he was very happy with the first eye, and he was also very happy with the second eye. So again, this is a Restor 3.0 exchange and removal for a Panoptix Trifocal Toric lens, and I hope this was helpful to you, and I thank you for your attention.